with these newer nurses, they come to their preceptors, their charge nurses, their colleagues, right? And with, little tears in their fluffy bunny eyes because this horrible thing has just happened. And we tell them to go wash your face and come on back to work, right? When we do that, even though we feel like we're toughening them up, what we're doing is we're compounding the trauma.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here, and welcome back to the Art of Emergency Nursing. If by chance this is your first time here, I'm thrilled that you're here. I'm thrilled that you're listening. For those of you who are back, thanks again for taking the time out to listen to this podcast. At the time of releasing this episode, it's the start of Emergency Nurses Week. I can't tell you how proud I am to be an ER nurse. I was trying to think of something special to do for the celebration, and then it hit me. I'm going to release what I think is the most powerful and important episode I've ever done. Months ago, my friend Dr. Lisa Wolf started telling me about a study she was doing around secondary trauma and emergency nursing. She was staggered by the results, and she kept promising me that it was going to blow my mind. Finally, a few months later, just before the manuscript was released, we sat down for this interview. She was right. My mind was blown. My gift to you on this Emergency Nursing Week is to make you start thinking and maybe make you a little uncomfortable. I truly believe this is one of the most important episodes of the podcast so far, so I hope you listen to it and I hope you share this podcast. Before we get started on the podcast, I want to give the usual disclaimer. The opinions and views here on the podcast belong to Lisa and myself. They're not necessarily reflective of our positions or any organizations that we either work and or volunteer for. With that said, enjoy this episode with my friend, the amazing Dr. Lisa Wolf. Oh yeah, stick around to the end of the podcast, and I'm going to tell you how you can win some great Art of Emergency Nursing swag. Let's get started. All right, Lisa Wolf, let's talk a little bit about PTSD.
I'm so excited. This is like super horrible Christmas type of stuff, right? So let me kind of lay out the longer story. So this is really contextualized so that the impact of it, is super great. So we started probably about 4 or 5 years ago on looking at fatigue, right? And part of it was somebody called me up and was like, why are we working 12-hour shifts? That's really terrible. And I was like, yeah, you're right. So we decided to do this 2-armed study. One was a really quantitative study about the effect of perceived sleepiness on cognitive function, right? So we gave these, it was very formal, quantitative. Here are the validated instruments. Here's the med question that we want you to do, and let us know how long after your shift and how many shifts in a row you work, like all this stuff, right? So that was one arm of the study, and that was kind of an interesting thing, but that's outside the scope of this discussion. The qualitative arm of that study really wanted to look at the experience of working fatigue. Like, what is it like knowing that you're so tired you can make a mistake, right? And so from that, we got a lot of information about that, but I think a really interesting finding of that study was that fatigue was both a cause and effect of workplace aggression, right? Of lateral violence. So, tired nurses are mean, right? We've established that, right? So that was kind of study one. That led us into this idea of workplace bullying and what that might look like. And so we did, okay, so how does that fit into bullying behavior? So we did that study. And what came out of that theoretical development was that, there was this dynamic, right? So you had nurses, you had charge nurses, and then there's this narrative, this dominant narrative about toughening up and developing a thick skin, right? So hold that. That's a really important thing to hold on to. And that, in the presence of that narrative, bullying behaviors were more prevalent. And those behaviors took the form of either direct aggression, making fun of people, berating them, that kind of stuff. But more commonly and harder to really pin down and address were these dynamics of exclusion or withdrawal, right? So we've talked about this before a lot in terms of especially new grads, like withdrawing support, withdrawing information, not telling them that this patient is really sick, or not telling them that this patient can be violent, right? Just to see what happens, see if they can cut it. Right? So once we establish that, now we look at the outcomes of that type of behavior, and what we see is clinical unreadiness, intent to leave. So there are nursing and there are patient fallout from that thing, right? So we publish the study, we publish the theory, people are like, hey, this is great theory, but in order to actually develop interventions, you have to show that the theory holds together, right? So in other words, you have to do a study about the theory to make sure that the elements go together the way you think it will. So when you do that, you have to figure out, okay, what are the things that measure those elements within the theory? So in this case, as one of the nursing outcomes, we were wondering if something called a secondary traumatic stress scale would be useful in measuring, because people talked a little bit about it being, traumatic to have this bullying happen. And also, this is partly Bill Schuler's fault, because he really wanted a resolution about studying PTSD in nurses. And I was like, go for it, man, because I really want to study PTSD in nurses. So as part of preparing for that theory validation study, we wanted to see if, in fact, emergency nurses reported secondary trauma as a result of bullying, right? So we're trying to tie these two, see if these two things actually go together. So last September at the conference, we did a formal study of secondary traumatic stress, which people are using interchangeably with the term PTSD. So I will also use them interchangeably. And so we had 125 people, we recruited 125 nurses to sign up for these focus groups. And as part of the sign up, they had to take the secondary traumatic stress scale. So we wanted to just get a baseline of what does this look like? And of those 125 nurses, hang on, I think I have this written down. The average score was 48.42. The clinical cutoff for moderate amounts of secondary traumatic stress is 39. Yeah, exactly. And wow. So that was for the groups. So we had two groups, right? Essentially, we had this very interesting Nashville experiment where, all of these nurses took the instrument, right? Filled out the instrument, but about 75 of them did not come to the focus groups, but 53 of them did. So was there any difference in traumatic stress between those two groups? And statistically, there was not. However, the nurses who came to the focus groups had a higher average of 51.83, and the cutoff for severe traumatic stress, they fall into that group, right? So everybody falls into the high traumatic stress.
All
group.
of them.
All of them. Just
Everyone.
about all of them. Just about. And so we see this in, we're like, whoa, what is this, right? So that's kind of that's where a lot of studies have stopped, right? There's a couple of studies out there of emergency nurses. They administer this instrument and they're like, oh, hey, guess what? Emergency nurses are, suffering from secondary traumatic stress. But we went a step further and we did the focus group piece of this. So we wanted to really understand why people were so traumatized, right? And so what we find here is that that nurses come into the profession without knowing what it's like, first of all, right?
Okay.
No surprise there.
Yeah.
But here's the problem, right? So we all have these incredibly traumatic experiences, right? They either happen to us, right? We are assaulted, we are, in some way injured or part of the incident. But most likely we are sort of drowning in other people's pain, right? And trauma and stress, right? Like all the time. And so most of us, like very quickly, you develop this, ready for it? Okay, we're going to go back, this thick skin, this way of sucking it up, right? Yeah, you're with me. So we do that. And so that's the only thing that allows us to do our work day after day, right? That's how we get through. We have a terrible sense of humor, and we're just,
If you think about it, that's like every ER nurse, like
exactly
every ER nurse, is a little screwed up. They're a little screwed up, and they're a little like, they laugh at some pretty horrible stuff.
Yeah.
And the funny thing, they see terrible things every day, and you're like, huh, all right, want to get some pizza? Let's get some pizza.
Yeah. Well, that's a big stick sticking out of your chest, right?
Yeah, that sucked. Okay, let's go.
Yeah. Right. Let's. You want a sandwich? I'll give you a sandwich. So here's the thing, though, right? So that's actually, here's news. That's very dysfunctional, right? And here's what it does to us. What it does to these newer nurses, and this is where I really think that we're onto something kind of huge here. With these newer nurses, they come to their preceptors, their charge nurses, their colleagues, right? And with, little tears in their fluffy bunny eyes because this horrible thing has just happened. And we tell them to go wash your face and come on back to work, right?
Yeah.
When we do that, even though we feel like we're toughening them up, what we're doing is we're compounding the trauma. We're making that experience so much worse for them because what we're not teaching them how to do is how to process it and manage it. And so they learn to do what we do, which is to stuff everything down. And that comes out sideways in a lot of ways. It is a very useful and productive short-term solution, right? Because it allows us to go through our day. But what it does is it creates, first of all, this environment where people can't bring themselves to work, right? They have to cut themselves off from the relational aspects of nursing, right? I can't get too deeply involved. I can't relate too much. I have to kind of just focus on the task, right? And so if we think of nursing as this, not just clinical exercise, but an intellectual, a relational, and an ethical exercise as well, the big chunk of that, the nursing presence part, right? The thing that allows us to actually be there for patients and learn the things we need to know and comfort them and do all those things, it's gone. It's gone. So what these participants reported to us was it was not just at work that they found themselves being numbed down. It was at home. It was with their partners. It was with their children. It was with their friends. Like they could not relate to other people after a certain period of time. And mind you, these are people who are obviously invested in this topic. So I would assume that they are kind of on the far end. But it was very troubling because they talk about, actually this is kind of weird, right? So I'm sitting there with my co-investigators and we're listening to this, and this guy says, this woman was like, well, I mean, it extends to everything. I'm driving down the street and I look around and I say, what if there's a car crash? Like, what am I going to do? What am I, just like this hyper alert. It's like when you go to Disney and you want to have your AED with you because all those people are just going to start dropping. But she's like, but I can't go to a restaurant and have anything between me and the door. I can't, and I got my back to the wall and the whole thing. And I was like, well, doesn't everybody?
You're like,
doesn't everybody do that?
I thought that's what we do. I thought that was the agreement.
Not what normal people do, Kevin. That's just what we do.
I gotta tell you, but I get it because you can't turn it off.
Right. Exactly.
Like you go to the grocery store and you see somebody who's like,
a little pale,
huffing and puffing down the thing. You're like going, I got to go to another aisle. She's going to collapse. And I joke about that. Now I joke about that all the time, but I'm like going, but the reality is, like, that's not normal. Like, that's not how people see people.
Right.
But
that's not normal.
So let me just give you a quick example. So yesterday I'm on my way home and I see a car accident, right? I see a rollover. 2 cars ahead of me. Like bam, boom, 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 over. And I'm like, holy shit, what just happened? Then I look in the road and there's a child standing in the road. And I'm like, holy shit, I gotta go. So I'm on the phone, I throw my phone down. I run out there and start caring for this child who's ejected from the car.
And standing there
Going like, what just happened?
Landing? What happened?
I don't even know. I seen this car roll and I was like, what just happened? And then there's this 5-year-old, like 4 or 5-year-old standing in the middle of the road. And I'm like, holy, because otherwise I'm like going, oh shit, somebody call 911.
I'm going to be late. Yeah.
So I go out there and start caring for this child I end up caring for this whole family and they were all fine. Like this child miraculously is fine.
Wow.
And I'm like
going, buy a lottery ticket.
Right. I'm like going, this kid's fine. But then I get in my car and I'm like going, fuck, I got blood all over me. And I'm like, God, I got fucking blood all over me. I was like, God damn it. I'm like, I'm going to get COVID. I'm like, this is terrible. And I'm like,
I'm going to get the anthrax. I'm going to get everything.
I'm going to get everything. And I'm sitting there going, and then I get home and I call my wife. I'm like, hey, I'm sorry I'm late. I just seen this. And she's like, oh my God, are you okay? And I'm like, oh, I'm fine. I'm
fine.
Yeah, I mean,
I did that too. I was driving my other 2 kids home from dropping the oldest one off at college. And right in front of us, a guy drops his bike and is like plastered to the road. And I'm like, I'll be right back. They're like, okay, Mom, we'll see you in a little bit, right? Go. I did, we do the whole thing. I get back in the car. I'm like, hey, everybody good? And they're like, Mom, you got blood all over you. All right. Anybody hungry? Like, we go to stop at a McDonald's on the way home?
So I talked to a nurse the other day who works in the emergency department I work with. And she tells me, she was telling the story to this group of people. And I don't know this girl that well, but like, we're like kindred souls, right? Like, cause we both do the same thing. Like I got you. So she tells me that there's, hey, there's a car accident in my neighborhood. This woman fucking plows into a tree and just dies, just deader than shit.
Oh, wow.
And just dies. And she's like going, and she's sitting there going, she goes, I found myself going, I wonder how she died. Like, I wonder, like, what exactly was the cause of death?
Right.
And then she's like,
torn aorta. Did she have a head injury?
Yeah. She's sitting there going, and I'm sitting there going, wow, this is. And then I forgot what exactly it was that she said, but she goes, something there struck me as like, wow, that's kind of funny, right? So she sees her, she's walking back afterwards, because her friends came and got her and told her, hey, there's this car accident right there. So she goes out there and the person's just dead. EMS gets there and they're like, yep, that girl's dead. And they'd start taking care of her. And then she's walking back, she's walking back and she's thinking to herself, like I forgot what she said. And she said, she goes, it just struck me as funny. And she's like, I'm sitting there going, oh my gosh, I can't laugh about this. Like my neighbors are traumatized. Like, and I'm sitting there with a smirk on my face going, whoa. and I'm like going, I feel that. Like, I get it. Mm-hmm. Like, I get that stuff. Like, it, and you think, and then I think to myself, like, am I a monster? Mm-hmm. I'm sitting there going, am I a monster? Like, I laugh at some dark shit.
Yeah. And, well, I mean, what else are you going to do? Is sort of
what else are you going to do?
What we said, what are you going to do?
Yeah.
But it's stuff like that, right? Like, I get it, you get it, but
it's not normal.
But it's not normal, and it's not really healthy in a way. But people describe like exactly that. Like when you can just sort of turn around and walk away and compartmentalize that in a way that you can move on with your day and not think about it. You're like, oh yeah, there was that thing. Yeah, this morning I saw that, right? Then what our participants talked about, and I totally relate to, right, is that it dissociates you from from you, right?
Yeah.
So one participant kind of talked about it, like she said, it felt like I was on a dimmer switch. Like my ability to kind of engage with everything got less and less to like all I could do is go home and stare at the wall when I got home. So, there's, I think, an amusing darkness, and then there's like something
Like-
that's a little scary.
Like, you need help. Like
You're cackling, right? Exactly. So, but along with that, people talked about really high levels of suicidality, like a lot, like not just I had a bad day, but and this kind of falls, like people talk about their colleagues who died by suicide and never left the ER, like they killed themselves in the bathroom after their shift, right? Like couldn't even go home, right? So we're talking about really devastating levels of trauma here. And so you would think that like, okay, here's 125 nurses and that's it, right? So then if you think, so we're using this instrument to test it for this big theory validation study. So we do the theory validation study, and so now we have a sample size of almost 1,800 people.
Wow.
Right? Who are not in a study about secondary traumatic stress. They're in a study about bullying, right? And the average score on that was also like very high. It was definitely in the moderate to high range. 43.78 was the average score. So of 1,800 people, right? So that puts them in the moderate level of secondary traumatic stress. And the higher the score, the more likely the nurse was to report an intent to leave.
Huh.
Right.
So how does this compare to, like, I'm sure the only other population I can always think of that always gets studied with PTSD is soldiers. Like, is there this number for soldiers? Like, because my guess is it's probably not 48 point something.
Right. Well, it's a really, let me just take a look. Because the thing is, what we're measuring here is secondary traumatic stress, which has a lot of the same symptoms, but it's about things that happen to other people that you bear witness to.
Okay.
Rather than being in the same situation.
Yeah, like I did.
However, a number of the folks that were in our focus group part of this study were veterans.
Yeah.
And they really, it looks like, let's see, PTSD in the military increased from 4% to 6% in over a 10-year period. Right. Or, let's see, National Center for PTSD says 30% of Vietnam vets. This is more Iraq or Afghanistan, 17%.
Yeah.
So, but again, the symptoms are pretty similar, right? Like the intrusiveness, the intrusive thoughts, you can't turn it off, avoidance, I don't want to go to work. Yeah. Those sorts of symptoms are certainly very similar, but the secondary traumatic stress scale was developed for social workers. Right? You think about a bunch of people who are involved in the trauma of other people.
Oh, yeah, totally.
Right. So, but it's useful in nurses. It's been validated in nurses, and so, but we're still talking about people who can't sleep at night, who are, bothered by the sort of repetitive replaying of things that happened at work. So a lot of people talk. I mean, we all have the cases that you can pull up at a moment's notice, right? And in that room, or with a lot of it is pediatric, right? A kid that age, or something like that. And so the participants described what we tried to do. I think we were trying to be really cognizant of re-traumatizing people, right? Like, you don't need to tell us the story.
Yeah.
Like, you can just tell us what happens now, right? You don't need to retell us the story. Although some people did, and I was kind of like, yep, Paul Clark and I are sitting there with like tissue bottle of tissues,
Yeah, holy cow.
So it was a really difficult and almost re-traumatizing study to do. But I think what it brings is not just the fact that we're a bunch of like really traumatized people walking around, but that there are clear fallout, right? So in other words, we think about like so many other things, right? Like moral distress, like burnout. Like, we tend to couch these in terms of an individual's deficiencies, right? Like, you can't handle it. You're not tough. You're right. And that actually plays into what some of our participants described as sort of the underlying cause of their suicidality. They felt that they could never be good enough. They could never do it well enough.
Wow.
They could, all those things, right? They could never be the nurse that they wanted to be. But this is a very systemic problem because it is the environment itself that is traumatizing. Right?
Yeah.
So if you walk into that environment, you are going to be traumatized. So what we have to do as a discipline, as a profession, is to acknowledge that, right? You can't make it go away. But what we have to do is we have to give people, like, from pre-licensure education all the way up, we have to teach them how to like maintain their sanity, right? Like, the answer is not stuff it down. The answer is process. What does this feel like? Do you need to take a break away from the ER for a while? Then let's create a structure so that people can do that. So the potential for a professional approach to this, I think, is really valid, because it doesn't just affect us, right? It affects our patients, because what people also tell us is that when they are kind of cut off and numbed down like that, they can't see signs of behavioral escalation, right?
Really?
Yeah. Because those subtle signs, if you're not relating to your patient as a person, if you're like, I got to go in and I got to take a blood pressure and then I got to go, right? If you're not really looking at them as a person, you're not picking up those subtle cues that they're starting to escalate, right? I mean, when someone throws a chair at you, you notice, but this is part of the reason that we could be, this is why things like CPI and MOAB are useless. Because you can't recognize the beginning in a busy ER when you're totally soaked in your own trauma, right? So, second thing, see, you're like, oh, I don't know, maybe. So the second thing is what they tell us is that they can't see signs of patient decompensation either, because they're not looking at patients as whole things. They're looking at them as a series of tasks.
Wow.
Yeah. So, I mean, we got to fix this. This has like a big, but this is when you think about it, it's like, oh, that's it. This is why we can't fix violence. This is why we can't fix consumer violence. This is why we can't fix bullying. It's because we haven't addressed this very root problem that causes nurses to not be able to fully focus on their patients. And this is the same thing, I would guarantee you, same thing with physicians. If I did this study in physicians, I would get the same. I told you it was going to be good, right?
Wow.
Mm-hmm.
Wow.
Right. So I've been living with sort of the profundity of that for a little while. But to me, that is the starting point as a discipline, right? We have to help people manage this, because the other thing is, why do people leave the bedside? Where do they go when they leave the bedside? They go to management. They go to education. They go to all the places that they can either mitigate that trauma or make it worse. Because if you haven't unpacked your own stuff, you're not going to be able to help like little fluffy bunny nurse do it.
Yeah.
It's way easier to just say, look, go wash your face, suck it up, I'll see you in 5 minutes. And we think we're being kind by saying, like, take a couple of minutes, rather than be like, hey, let's process this.
Let's talk.
Let's talk about
it. Wow. I'm just as you talk about this, I just think, okay, I have 18 new grads that are going to start in the ER this week.
Yeah.
And I think that, like, every one of those guys is going to be in this boat.
Oh, absolutely. Every single one of us is.
Yeah. And, like, I don't know. But how is it that some people seem to, like, okay, we probably have some dysfunctional behaviors. Like, we're probably a little messed up, but, like, overall,
like, pretty functional.
Overall, like, I get up in the morning, I don't feel like putting a gun in my mouth. I feel okay. Like, I'm overall a pretty happy guy, overall pretty pleased with life, pretty good. What makes the difference between you and I, who are, like, functional adults? We get up, pay our taxes, do our jobs, and may make some crass jokes, but other than that, we're okay. And somebody who's sitting at home on a Saturday night going, maybe I'll just kill myself.
Yeah. Well, I gotta say, I think even, I don't know. If I knew that, man, I'd be picking horses. I wouldn't be doing this. To be able to sort of pick out the, and this is the constant conversation that we have about resiliency, and are people born with it, or do they, the thing, I mean, we've been doing this kind of a long time. I've been doing it, God, almost 25 years. And I think that I recognized early that this could really screw you up if you weren't really aware of it and took very deliberate steps to manage it. So I've done a couple of things. Like, I run a lot. Until COVID shut me down, I fenced, a bunch of times a week. And so there's, like, this physicality, right? Like, you can just run it out, or fence it out, or whatever. I used to actually go to Taro's house after work, and he lived, like, between my house and the hospital, and I would stop at his house and I would have a beer, and he would ignore me, and I would, like, vomit my night, right? And I'd finish my beer, and he'd be like, okay, you done? I'm like, yeah. I said, okay, I'll see you tomorrow. Put the beer down, and I go home, and I could be a person, right? Like, I could relate to my children, and, because it had to go. It had to go somewhere.
Yeah. I mean, and I know I do that too. And there's some days that, I would come home and tell Jenny and be like, oh my God, this is what I had to deal with today.
Right.
Then there were other days I was like, I don't want to talk about it.
Yeah.
Like,
I don't want to talk about it.
This is too heavy for you.
Yeah.
Like, and I was telling her, I forgot what we were talking about. And I was telling her one day, I said something about, like, I've seen some horrible shit. Of course I've seen some horrible shit. Like, I worked in an ER and a pediatric ER for a fucking long time.
Yeah. Yeah.
Yeah. I've seen terrible, terrible things. And she's like, how come you've never talked to me about that? And I'm like, I want to be like, your little cute bunny ears just can't handle this.
Right.
No, like you wouldn't be able to sleep.
Right. You would be like, how, I remember one night I was telling him about it, and he looked at me, he's like, this is your job? Like, you do this? Why do you do this? Right. I was like, right. Well, I don't know. Yeah. Or you go home and like hug my kids extra tight. They'll be like, you had a bad day at work, didn't you? I'm like, yep.
Yep. Bad day.
Bad day.
You're like, talk tomorrow.
Yeah. Just like, we'll just snuggle. I'm like, you're the best. You guys are all the best. Yeah. But a lot of people don't have that for whatever reason. And I wonder sometimes if as nurses who fix stuff, and we're used to kind of being very competent and sort of emotionally tough, because that's what we're told we have to be. I wonder if if one of two things. One, we sort of feel like the people around us are ill-equipped to handle it, which is true. But do we pick people that we need to protect, like, on purpose as well, which is a totally, like, beyond the scope of this conversation, but sort of what are the attributes of the people that we choose to partner with or live with or whatever that also make it really difficult for us to rely on them for emotional support. You're looking at me like, whoa, mind blown.
No, but like, I mean, I don't know. Like, the more I listen to you, the more I think I'm probably okay. I think I'm okay.
Mm-hmm.
But then I think of like all these people I know that just so aren't. Like, I mean, like, how many nurses do you know that like pick the fixer upper that like going, oh my God, this guy's gonna put you in a grave?
Exactly. I'm like, why are you working so much overtime? Oh, my husband lost his job again.
Oh yeah, you're like.
I'm like, wow, what is that? Is every nurse here like the sole support of their family, married or not? Is it like, what's going on
here? It makes you wonder, because like I remember, I worked with a nurse.
This is the study I want to do. This is totally the study I want to do.
Work with a nurse who's, beautiful, funny, hilarious, like hardworking, super nice, great, and just the nicest person, and like is just married to a deadbeat. And you're just like going, God, that guy, like your husband, oh, he doesn't have a job again. Oh,
yeah. But don't worry, I'll fix it. I'll just pick up a couple extra shifts. It'll be fine.
Yeah, we're a couple extra shifts. We're okay.
Right. Yeah.
Until finally, the smart ones are like, you know what? I'm done. Yeah. I'm done.
I could work this hard and have all this money to myself.
Yeah, exactly.
So yeah, I mean, that's just sort of a side thought, but it occurs to me why it's so challenging to manage this at home, right? Like why, I mean, and part of it is also there's only so many times that you can talk about work before people are like, please, enough, like we're eating here, like I get it. Yeah. A lot of the participants talked about wanting to, like they found like the critical incident debriefing stuff was singularly unhelpful because they felt like it was at a time that was never convenient. It was run by people who weren't there. Like really what they wanted to do was talk to the people who were there at the time, like, reasonably close. Process, right. And just kind of do whatever we do. But without like sort of an organized outsider kind of managing. So, yeah. So that makes it really hard too. I think I finished coming out of the last focus group at the conference last year, and there was a pet therapy booth. Did you see that? That's awesome. And I'm talking to the lady, and I'm petting this dog, and I'm like, this is what we need. This is the intervention. We just need we need a puppy room.
You said this.
Right?
Brilliant idea.
Yeah.
Brilliant idea.
A puppy room so that people
at the end of your shift, like, yeah, just go pet with the puppies, go play with the puppies.
Yep,
and
then hour at the end of your shift, play with the puppies and let it all out and go. I'm telling you. But, like I talk to my students, my unlicensed students sometimes, and I'm like, get a hobby. Like, get something that is going to make you feel good because you're going to need it, right? This is a good time to start running or get into yoga or something because this is a challenge, and if you don't come up with ways to manage this, you're going to not last long in the profession, or you're going to still be here, but you should leave, right? Because you're going to be terrible.
Like so many people are in that boat, right? In that boat right there. Like you're going, why are you still a nurse? Why are you
gotta go?
Like you hate it here. Why stay? Like, well, I'm going to hate it anywhere. Like,
right. But I really think that rather than looking, so here I think is the takeaway or the aha moment from this study is that a whole lot of really bad behavior in departments, I think, might be at least in some way, related to this really stuck down trauma that none of us are processing. Like, I think it comes out sideways. I think the dominant narrative of toughen up, get a thick skin, like that's all about suppressing the stuff that we see, right? Like that's all about putting it aside and not managing it. And I think that if we start developing interventions or programs, like my idea, for the ENA, I was like, if you're teaching TNCC, you should also be teaching trauma processing. If you're teaching ENPC, you should also be teaching trauma processing. Like that should be woven into everything.
Everything.
And we should put it in our work with for preceptors and for charge nurses and for leadership, and like, get it together, guys. Like, this is a disciplinary problem that we have got to tackle, which may mean that you're going to be a little uncomfortable.
I mean, can you imagine if this was like kind of woven into all the courses that we teach? Like this could help.
Right. Well, I mean, I spoke to after, I don't remember. Oh, I know. So I was teaching med surg this spring. And so I do a unit on trauma, like musculoskeletal trauma and stuff like that. And so, that's my favorite class. But this time around, I took about half an hour and talked about trauma processing and, what it meant and why it was really important and how it would, if they could get a handle on it, it would ensure some longevity in the profession. And if not, they would just hate every minute of it after about 2 years. After other people dying stops being interesting, and just becomes horrible. And a few days later, I started getting emails from the students who were like, this was so helpful. Like, I had no idea. And this was like, because they don't talk about it in nursing school. Like, it's all, take your lamp and go make people better, right? They don't talk about this.
So let's talk about trauma processing, because I think I know what that means, but I don't know that I know what it means.
Yeah.
And other people may be in the same boat. Like, what do you mean by trauma processing?
Yeah, well, what I mean by it, and I don't know whether this is the professional, approach to it, is the idea that it's important to understand the effect of these experiences. Other people I think a lot of people feel like, well, that didn't happen to me, so how can I possibly be traumatized, right? So to understand, like, part of nursing is that we are part of the web, right? Like, we are intimately engaged with other people at this moment of trauma and horror and pain and all those things, and you can't get away from that without it affecting you. And so to understand that that's a thing, first of all, and that it's normal and there's nothing wrong with, like, feeling like a human, right? Like, you can be upset and you can be sad and you can still take care of patients while also being upset and sad and having, valid feelings about it. Most of us can't have the breakdown that we want in the middle of a shift, but they're
not going to work,
right? So there's a way to kind of practice putting things aside just for a little while, right? Like, till the end of the shift. And then you can be like, okay, I got to talk this through. And so this is how I'm feeling about it. How might I approach this next time to make this a less difficult process? Do I need to go for a run? Do I need to go for a walk? Do I need to talk to somebody? Do I need to write it out? Like, do I need to journal? I mean, I think the way that people manage this is going to be as individual as people are. But the idea is that therapists have therapists, right? Like, you can't be a therapist without having a therapist, right? So that's kind of one of the rules. And part of that is so that you can process how the things that your patients tell you in therapy, triggers your own stuff, right? Or, am I responding to this appropriately because I have this experience over here, right? Like, so you see how your own experience gets affected by what you see and what you get involved in, right? Like, there are patients that we take I don't want to say better care of, but we hover over more because they remind us of, our moms, our siblings, our children, right? Like, so, and so trauma works the same way, I think, right? If you're, I think possibly the worst thing that has ever happened to me at work was I was taking care of a woman who was dying in my hands of a saddle block pulmonary embolism, who was my age with children my age, and her husband, who was my husband's age, was standing outside the cubicle as we were pouring TPA into this woman in an attempt to break this thing up. And the physician that I was working with, we were looking at each other and we're just crying because we know this is not going to work, and we have to go and tell this guy that we can't save his wife. And so we're actually doing our work. And I think if anybody else had been in the room, we would have found that a little more challenging. But I think we just did it, right? Like, we cried and we worked, and it, came out the way that we thought it would. And it was terrible, but it was doubly terrible because I saw myself in the bed, right? And I think that all of us have these moments where, like, you take care of a kid who's your kid's age, right? And you can't do that without seeing your own kid there, and that's terrible. But you can't stuff that away. You have to talk that out. You have to figure out how to make that, to integrate it without making it take over every time you walk into a room to take care of a kid. You know what I'm saying?
Yeah. One of the things that as I was charging nurse at the ER, I'd see so much, you'd see so much stuff. You just did. As a level 1 trauma center, it's just always busy. But we had a guy who coded he was on his way from the parking the parking lot of the hospital, and he was a nursing student on his way to do clinicals at our hospital. Right. So this is one of the nursing students where they show up, they do their rotations, they meet their teacher there, and then they, go off and, did their thing. And, this guy was, I can't remember if I think he was on his way to his shift, or maybe he was on his way home. I think he was on his way home from his shift. And he was in the shuttle van, and he coded, like he just collapsed. And this was a guy who was probably like a big dude, like wearing the same uniform I had, 10 years before.
Yeah.
And like, it just bothered me. I was like, oh my God, this is the fucking guy. Like, what if this was me? Like, what are we doing? I'm like going, we don't know anything about this guy. But I was like, but he's from my program. He's the nursing program that I went to. And I'm like going, okay, I know how to find people there. So what I ended up doing is I ended up calling the dean. I go, dude, I know this is like,
it's bad, dude. You got to come down.
The dean's, the dean's a friend. And I was like, I got, I know you don't know who this kid is, but you're going to have to find out who this kid is. And, we had his name and stuff, but we didn't know anything about him. And we had to reach out to her, and, she made phone calls and found the family for us. And, he was, he didn't die in our emergency department, but he didn't die long after. And I just remember being like, just devastated about this guy. And I'm sitting there going, I've seen this story 100 times, 100 times. But for some reason, that one, like, there's just too much to you relate to. And you're like going, oh.
Yeah, absolutely. I always found it much easier. I love taking care of children. I have no problem with it. But my youngest kid is 15 now. So I have no problem taking care of little kids, right? But I couldn't when they were little, right?
Yeah.
It was really hard. So, I'm great with boo-boo elbow and stuff, but, the really, really sick kids were hard.
Yeah.
So, I think there's just sort of this recognition that it's not the people who can't handle it that are traumatized. It's all of us. And so it becomes the responsibility of all of us to help each other through it, not make it worse. So, our participants really talked, especially the ones who are newer, really talked about the need for someone to show them how to manage that experience, right? They were like, I just wanted one of the more experienced nurses to like help me through it or show me how to process it, and they wouldn't. They basically said, "Suck it up." And me, right? So this idea of bullying really revolves in a big way, I think, around this idea of are you going to let what you see bother you in the moment or not?
Wow.
Yeah.
I I just, I just keep going back to these residents that are, we have residents starting this week,
Right.
new ER residents, nursing residents starting this week. And I just think to myself, man, you guys picked a hell of a time to become a nurse.
Right. No kidding.
Right.
But here's the thing, right? So this is the group that we don't want to be like, hey, so this is what you signed up for, right? Like we don't want to do that because now, right? So you think about being traumatized, right? Something happens. The compounding of that trauma by your colleagues who won't acknowledge that this was a terrible thing that happened, right? And now think you're going to add another layer because now your organization or your institution is going to tell you, yeah, just go back to work, right? So let's think about this in the context of COVID. We have new nurses coming in and there are people dying all over the place. And they're like, holy shit, what do I do with this? And what if I die? And why aren't you protecting me? And so what we have is institutions that are saying, yeah, don't worry, you'll be fine, get back to work, right? It's sort of what we talked about when we talked about ethics, right? Those nurses who walked or who sat in the break room waiting for reinforcements, right?
Yeah.
Because it is both morally distressing and psychologically traumatizing to be placed in a situation where people are dying around you and you can't do anything about it because there aren't enough of you, because you can't go into the room because you don't have the appropriate equipment, or you have to make the decision to go into the room without the appropriate equipment. This is organizational violence, and this compounds all of the other stuff.
Man.
Yeah. So this is where like the revolution comes, right? This is where we say like this is not acceptable.
Yeah.
It's not acceptable in our colleagues. It's not acceptable in our leaders. It's not acceptable in the system.
Wow.
I'm telling you, revolution, not exodus. Yeah. So, I think it's like horrible stuff to uncover, but like everything else, if you have a sense of what's going on, you can start thinking about how to fix it, right? If we have this idea that like, well, people are mean to each other and that's how it is, and that's too bad and whatever, we should make everybody be nice to each other. There's no answer to that. But the idea that like some of this comes from the inability to manage what we see and it comes out sideways and we hurt each other, right? If we can start addressing that, then it may go a long way toward changing the environment in which we practice.
Yeah. It's true. I guess you got to know the enemy, right?
Right. Here it is, man.
No.
That was a hard study. I was like, just go have a drink, man. That was awful.
Yeah, right?
Yeah.
So what's the next thing for this study?
Well,
where do you go from here?
Where do we go from here? Well, what we're going to do is now that we've done the theory validation study, and I'm hoping that will be published in the next 6 months or so. It has very complicated statistics in it. So it takes a little while longer to write. But I think what it does is because it says, okay, this theory of workplace bullying hangs together, right? Like the elements are correct. We have described the dynamic of this problem in a way that lens, like, so the best thing about developing a theory is that it's a map, right? So a middle range theory, for those of you who have repressed this from nursing school, a middle range theory is a description of like a situation specific phenomenon. So workplace bullying in emergency settings, right? What are the things that are very particular to emergency nursing that create this situation where bullying occurs? Well, now we know, right? We know that the charge nurse can be the driver. We know that this narrative of toughening up and thicker skin is potentially linked to this idea of trauma, unresolved or unprocessed trauma. And so what we can do is we can start to develop interventions in the training of, say, charge nurses specifically, because they are kind of the linchpin of this, to really get an understanding of how they see their role, how they are trained, and then provide education about managing people in a way that is sort of non-punitive, non-judgmental, and accounts for this particular phenomenon of unresolved trauma. The other things that we can do is start really talking to nursing students about this, and start having them build up some tools, right? Instead of just being, upset that things happen, right? This ability to sort of process through and understand how their own experiences kind of put them in a position where they may relate overly, to their patients, and how maybe not to do that. We can talk to leaders about understanding. I think the idea that it is an individual problem gives leaders who don't know otherwise just sort of like, well, that person's trouble, or that person's problematic, or that, whatever, right? So they're not looking out for them in the same way. And I think managers also have a big problem because they manage not only their own trauma, but the trauma of their staff, right? So we got to put some stuff in place for them. That and in really infusing all the education that we do with the idea of processing these events kind of as they happen, I think is, there's a lot of stuff that we can do, and we can start doing it kind of all at once. I'm working with a group of folks who are doing a study that comes out of this study, actually the PTSD study, but is looking at the effect of trauma on clinical decision-making, right? So the idea that people get sort of hamstrung by their own stuff, right? And looking if that actually affects the goodness of their clinical decisions, right? So think about this. Do you do simulation with your little fluffies?
We do a little bit of simulation, not enough. We don't have much for anything.
Okay. Because the other thing that I want to think about doing is I wanted to do this with my students at UMass because they have a fantastic simulation, and they do a lot of teaching via simulation, is have them go in and have somebody come in and be like, what are you talking about? Like, you don't know what you're doing. And watch them see if they stick to their guns, right? Like, I wanted to do this study a while ago before I knew about this trauma stuff. It's like, if you insert an authority figure who challenges their perception, how do we teach them how to stand their ground? How do we teach them how to be confident in their own decision-making, right? But now added on to that is this layer of trauma.
That'd be interesting to see.
It would be kind of scary, given that we know that large swaths of the profession have more than minimal levels of secondary traumatic stress.
And and then we've said this before in another podcast where, like, how many nurses, like how many people go into nursing because they're trying to fix their own shit?
Yes, exactly.
Like so many.
Right.
So many.
Right. Right. And so it's almost like you should have to go through, like, I don't know, an ESTA weekend or something before you go to nursing school. But it's really clear, like, we've all seen people who are like, hey man, go get some therapy and then come back to work. But like, you can't work your stuff out here. This is bad. This is bad for you. It's bad for the patients. Like, not cool.
Yep, absolutely.
Yeah, me too.
Holy cow.
Yeah, right. See, you've been wanting to talk to me about this for a while. I hope you can be careful what you ask for.
Be careful what you wish for. Now I'm gonna be up all night going,
Oh my
how do we
God.
fix
Yeah,
this?
exactly.
Um, I think the thing that one of the things of all the things you said that really sticks with me the most and kind of troubles me the most
Mhm.
is how many nurses talked about being potentially suicidal.
Yeah, that was very surprising and very disturbing. They talk about it. They talked a lot about it with themselves, but also with colleagues, and sort of this idea that a colleague would die by suicide and nobody would say anything, right? Like, there wasn't any reckoning with that, and I think that was that people verbalized that as being like really difficult, sort of not knowing what happened. It's I think the rates. I mean, now this is really coming out. Like, so we know that physicians have very high rates of suicide, and I think nurses do too. They just don't really keep stats on it. There's one study out of California, um, which indicates that nurses have much higher rates of suicidality than other professions, um, and I'm not surprised. And people would talk about it in like these sort of like intermittent things, like you're driving to work and you're like, huh, it's a really nice bridge there. Like, oh, maybe, maybe I just take a few weeks off, like I could use a few months off from work,
Yeah.
you know?
I've always thought one of the coolest ideas I thought of that, we talked about in an old job and never actually made happen was, we were talking about, how many ER nurses were so burned out. And then we had, this clinic, we had this like urgent care where like the nurses were just bored. They were just like, yeah, there's not much going on here. And like, I almost want to be like, okay, we need to rotate you guys out. Like we need to,
Yeah.
You do 3 weeks, you get to go do a week at the resort.
Right.
and just kind of regroup, get good again.
Do a week in newborn nursery, like go hug some babies, go and
something.
go and work
and just
sports medicine.
do something else for a little while. And it's like, what a great idea that would be just to give them a little bit of a break.
Yeah.
But I mean, and I was talking about this just the other day. There's a nurse I used to work with that, he was probably, I don't even know how old he was. He was probably 50 when I met him. And he was a, former trauma nurse, former flight nurse, like been there, done that, seen it all, done it all. And he was coming back to the ER after, I don't know, like a couple year stint in like, ortho clinic or something. And we were like, I was like, dude, you were like a flight nurse. You're like a badass flight nurse, trauma nurse, worked over at the university. And this was before I worked at the university. And I go, and then you just like started doing like, ortho clinic. and then now you're back. I'm like, what's going on? Like, why would you do that? And he was like, well, Kevin, he goes, you may not appreciate this now, but at some point in your career, you're just going to get tired of seeing teenagers die.
Yeah.
And I was like, and I remember going, whatever. And then now, like, there's so much appreciation I have for that guy because there's so much that he said or did that I never fully appreciated until I was like, all right,
really in it. Yeah.
This guy's a pretty good nurse. Like as much as like I was a tech at the time and I remember going, oh my God, I hate working with this guy because he's such a pain in the ass. Then when I became a nurse, I'm like going, he was a pretty good nurse.
Mm-hmm. Yep.
So Wow. Wow. That's heavy. Heavy shit.
Yeah. Well, I think I'm excited about it. It seems really weird that I'm sitting here like so excited about this information, but it and probably this is why I'm functional, right? Is because I'm optimistic, right? Like, oh, I know what the problem is. We can try to fix it, right? Rather than, there was certainly a temporary like, oh my God, this is so heavy. Like, I don't even know what to do with this information. And I think my colleagues who worked on the study with me would agree. We just kind of sat there and we were like, holy shit. This is some big stuff. But the more I think that we worked with it, it's like, okay, this is terrible, but there's a roadmap here. And this is, honestly, this is why I do mixed method studies. This is why you want to understand why people score like this on valid instruments, right? What is going on here and how do we fix it? And I think that's where we really got to the point of like, this is the root of a lot of bad behavior, and people are taking it with them away from the bedside into management, into like positions of influence, and that's a terrible thing. Like, we got to fix that.
Yeah. Now, you mentioned this theory that you guys had and this theory that you've now validated. Like, how big a deal is this? Does every researching nurse come up with a theory?
No, not really, actually.
Or is this like something that this like people like 20 years from now are gonna be like, do you guys hear about this?
You could use that in a study. You could be like, framing this study is the, theory of workplace bullying in emergency setting.
Wow.
Wolf et al., 2018. Yeah, I mean, so the weird thing is like, so when I was a doctoral student at BC, you can't get out of Boston College without a theory. Like, they're like Callista Roy teaches there, right? Like, so, you can't get out without a theory. So my dissertation, it was a testing of a theory of decision-making in emergency settings, right? So it was like a theory of triage. Like, why do people make bad decisions in triage, right? And so people have used that actually to frame their own studies about triage, this sort of idea of an individual within an environment. And so, they're useful, but certainly they're a lot of, not everybody comes up with them, right? Just because it takes kind of like a different orientation. You have to have a much broader orientation. And I think a lot of researchers study like, one thing, but a mile deep. And I've been lucky enough with this job to have the freedom to look at sort of the environment, like workplace environment, all of it, like, and just kind of follow where different studies take me, right? And in this case, following this wandering path led us to, I think, what is a really significant finding. So,
yeah, that's cool.
Yeah, it's fun. Generating theories so you don't have to. It's sort of my job.
It's a good job. It's a good job.
Yeah.
So, all right.
Yeah.
Holy cow.
Yeah, I'm gonna go have a beer now. So.
Right. Totally.
Yeah.
Totally. I might start drinking.
No, don't you do that.
No, you got to figure out what we're going to talk about next.
Oh, don't worry. I'm sure we'll come up with something.
Ain't that the truth?
Puppy therapy.
Puppy therapy. Like, how do we study that?
The
how do we study
that? The future.
You're making me want to do research, and that makes me feel dirty.
I win. It's the long game.
Lisa, as always, I can't thank you enough for your time. You're amazing. This is going to be an amazing episode, and thank you.
Awesome. You're welcome. Thanks so much.
We'll talk to you soon.
All right. Talk to you soon.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.
Hey everybody, Kevin McFarland here, and I told you I was going to tell you how you can get your hands on some Art of Emergency Nursing swag. It's super easy. If you have an Apple device, what I need you to do is go to Apple and leave a podcast rating and review. Now, leave an honest review. Tell me what you think of this episode. Tell me what you think of all the episodes, but leave me an honest review and an honest rating. Do that rating and review, do a little screenshot, and send it to me on social media, either Facebook or Instagram. You pick, don't care. I'm going to put your name in a drawing, and I'm going to draw one person who does a review this week. This week, the first week that this podcast is out, so Emergency Nursing Week. One of the people who does a review this week is going to win a super cool Art of Emergency Nursing shirt. You can see the shirt on Facebook and Instagram if you're wondering what it looks like. It's pretty darn cool. So now if by chance you've already left a rating review, I'm not going to leave you out. Don't worry, we got you covered. If you've already left a rating review, it won't let you do another one. So just do a screenshot of that and send it to me on social media so I know who did it and I know whose name to put on the drawing. Do that, get your name on the drawing, and somebody is going to get a cool shirt. I'm going to be doing giveaways all the week of Emergency Nursing Week, so stay tuned to social media. Thanks, guys.